Mucous myoma, on the other hand, of any size, can impair the fertility and require hysteroscopic or resectoscopic resection. In case of multiple myomas of varied sizes, a preoperative MRI for mapping is justified. So incision, vertical, transverse, elliptical incisions, all of them cause similar blood loss because the normal vascular anatomy is distorted by the fibroid. Use of an ultrasonic scalpel and aqua dissection or careful vasopressin infiltration. So normally we just inject normal saline to prevent the side effects of vasopressin, or you can just dilute it in 5 units in 200 ml of normal saline and inject 10 milliliter per centimeter size of the myoma in the right plane. This can reduce the blood loss and improve the wound healing. So the pseudocapsule is avascular and the myometrium surrounding is hypervascular. So closure can be done in multi-layers, ensuring proper hemostasis, elimination of dead space. So baseball suturing can decrease the risk of adhesion formations, particularly when you are using barbed sutures, as it will avoid the exposure of the suture to the peritoneal viscera. So this is uterine ligation or occlusion, which is done at the origin from the internal iliac anterior division to reduce the blood loss. So this case was done just 3 days ago by me. This particular fibroid was 8 centimeter myoma. Here we have started with the retroperitoneal dissection, just lateral to the infundibulopelvic pelvic ligament. So there is some controversy that the occlusion can affect the ovarian reserve or the placental perfusion. So therefore, there is a shoelace technique as well. It is an alternate method that can facilitate temporary occlusion. So here we can see close the endometrial defect using a running 2,0 polygalactin 910 suture, taking care to avoid suture entry into the uterine cavity in order to prevent intrauterine adhesions. Close the hysterotomy incision in layers using a 14 by 14 bidirectional barbed PDS suture number 0 on a 36 mm half circle taper point needle. So this will help in the suturing and closure of the endometrial cavity. Plan to facilitate the conception of such a woman 3 months after the surgery. So this you can see, it is so close to the endometrial cavity, the myoma, and this can be closed with a bidirectional barbed suture. So adhesion prevention is, you have to adhere to the microsurgical principles, peritoneal instillation with ecodextrin 4%, surgical barriers like Interseed, Gore-Tex, Ceprafilm. There's no conclusive evidence to support the effectiveness of heparin. So installation of antibiotics in the peritoneum or hyaluronate or fibrin sheets, they are all tried, but there's no evidence. Hydrosalpinx. So this is another case report where a 35-year-old para-1 live one presented with history of infertility since 4 years. Ultrasound findings revealed retroverted fixed uterus, bilateral hydrosalpinx. So this is the video here. It's a Fitzhugh-Curtis syndrome. So the widely accepted implication of reproductive surgery is performing salpingectomies in order to optimize IVF outcomes in the patients with hydrosalpinges. A study demonstrated that oocytes retrieval done 4 to 6 months after the salpingectomy yields in higher cumulative pregnancy as well as the live birth rates. As you can see, this is the left side, huge hydrosalpinx, which is retort shaped. There are bowel adhesions in the pouch of Douglas. There's a seedling myomas, right side hydrosalpinx as well, low ovarian volume, adnexal adhesions. So these were all dissected. Now endometrial polyps, multiple clinical studies have shown that surgical removal of polyps in patients prior to IVF or IUI can improve the reproductive outcomes. They are localized outgrowths of the mucosa consisting of glands and stroma. So the formation of the polyps can be related to inflammation, mechanical damage, disturbance of local hormonal environment, or excessive growth of the basal layer of the endometrium, imbalance between cell proliferation and apoptosis. You have to tell this when the patient asks you, why is what is this condition, why is it happening due to? So they have been diagnosed hysteroscopically in 4% of all women with unexplained infertility and 15% of women with eumenorrhea. So it can affect with implantation, it can become a physical obstacle. Their studies have shown increased level of glycodelin, which inhibits the natural killer cells. So polyps are unresponsive to progesterone stimulation. This can lead to defective implantation. So this is another hysteroscopy video for polyp. So it's a gold standard for diagnosis as well as therapeutic excision of the polyp. Here we are excising it using a 5 French scissors. You can also use a resectoscope Type of polyp doesn't matter for the recurrence, whether it is pedunculated or sessile. It can also be due to genetic aberration of the endometrial cells if it is not removed completely the stalk. Type of nature of the polyp, if it's hyperplastic polyp without atypia, it has a more chance of recurrence than that of benign polyp, that is 43.6% versus 8.3% in a study. So healing occurs within 1 month, and infertile women should be ideally instructed to achieve a pregnancy 1 to 2 months after the polypectomy before the recurrence chances can increase. Avoid the use of diathermy to prevent adhesion formation. So coming to adhesions, 30-year-old para-zero abortion, one woman came with secondary infertility with a scanty menstrual flow. So there was a history of DNC. Let's come to the video. Hysteroscopy was performed using a 4 millimeter 30-degree rigid telescope. This is the internal os. What you see is just a pinpoint. It looks like an ostia, but it's actually the internal os. So here we have done the scar excision in order to pass the telescope inside. Even though we have done preoperative preparation with the mesoprostol, the internal os is almost cicatrized, right? So these features are suggestive of Asherman syndrome, and in this particular case, it is stage 3B. Then what we have done is perform the adhesive lysis with the 5 French scissors. If you think initially, you may think that that's the fundus, but as you go on dissecting, you understand that the fundus is further beyond, and that's actually a complete obliteration of the anterior and posterior walls. So what you need to do after this adhesive lysis is just you can keep a intrauterine Foley bulb or some sort of hyaluronate gel, and this can prevent again recurrence of these adhesions. There is also a special type of a catheter, hysterocatheter, and along with that you can start oral the hormonal pills which can proliferate the endometrium, promote in the healing, estrogen and progesterone pills. So overall conception rate after the adhesive lysis is around 50%. Most of the successful cases will conceive within the first 12 to 18 months, sooner more than later. So hysteroscopy can improve the menstrual pattern, conception rates. So just note that once you have done this intrauterine adhesive lysis, patient can have ectopic pregnancies, increased risk of placenta previa, accreta, abruption. So now coming to uterine malformations, it is associated with recurrent pregnancy loss, obstetric complications, miscarriages. So the prevalence is around 4.3% in fertile women, 3.5% in infertile, and 5 to 25% in patients with RPL. So it's known that the sensitivity of the endometrium to the pre-ovulatory hormonal changes and vascular epithelial growth factors receptors are lower in the septal tissue than versus the normal. So pregnancy rates are shown to be higher after the septal resection. That is the ultrasound showing the different Mullerian abnormalities. So now this is the laparoscopic view. This was a case we have done just last week where there is a bicornuate uterus with multiple seedling fibroids. And this patient was actually posted for laparoscopy to medialize these uterine horns because there was a difficulty in passing of the embryo catheter at the time of embryo transfer. So it was almost on the lateral pelvic walls at the external iliac vessels. So what we have done is we have medialized these vessels from the lateral wall and put the Merceline tape in order to fix it after the bladder dissection and the retroperitoneal dissection. So septate uterus is associated with reproductive wastage, but you know, before operating these cases, just rule out other causes of RPL. So this is a video of hysteroscopic metroplasty where the avascular central portion of the fibrotic septum, it is divided, and after this division, the conception to the patient is advised on 5 to 6 weeks gap. So this can be achieved by mechanical scissors, lasers, or resectoscope electrodes. We use generally bipolar underwater electrodes. So here you can see clearly there is a midline septum. So here I am lysing this with the 5 French the scissors with the operative sheath. Concomitant laparoscopic as well as ultrasound monitoring can increase the safety and security during the septal resection. How do you know when to stop? You start seeing some capillaries, and that is the point where you are almost at the level of the ostia. That point you must stop. See, here you can see there are some capillaries that are starting to come. This is the point where the septal resection is complete. and then you can keep a Foley's and start the OC pills to the patient. Adenomyosis and endometriosis. 29-year-old woman has presented with severe dysmenorrhea, dyspareunia, primary infertility, trying to conceive since the last 5 years. Saline infusion ultrasound revealed blocked fallopian tubes. 3D ultrasound reveals a 7.2 by 5.8 centimeter left ovarian endometrioma as well as a fundal adenomyoma of around 5 centimeters. The MRI confirmed increased junctional zones thickness, 12 mm. Laparoscopy was planned. So treatment are controversial. Medical therapies can be given with GnRH analogs, progestins, COCs, NSAIDs, aromatase inhibitors are under study. Selective progesterone receptor modulators such as misoprostol, ulipristal, they are under investigation. Drawback is only temporary relief of symptoms and lack of evidence. So this is for adenomyosis. Now this is the laparoscopic video of this case who has presented with grade 4 endometriosis, and the patient has a large left ovarian endometrioma. So excisional adenomyomectomy involves removal of the focal lesions, while myometrectomy is the surgical debulking of the diffuse adenomyosis. Non-excisional treatments aim to induce necrosis of focal or diffuse adenomyosis through selective vascular occlusion or by the use of focused ultrasound or thermal energy. So in some cases, a combination of surgical and non-excisional methods, okay, the ablation that is used to achieve maximum cytoreduction and reduce the amount of damage to the myometrial tissue. So remember, when you have a case of adenomyosis, the uterine muscle becomes brittle. It is more prone for rupture. So please consider the obstetric outcomes and then plan your surgery. Here we are dissecting the pararectal spaces. We are exposing the ureter to prevent its injury in the case where we have planned the cystectomy. So here I am opening the left ovary. So you can see there's a clear-cut chocolate cyst. So we are going to peel that away. So the only thing is it can cause a little bit drop in the ovarian reserve. So that is why we prefer now carbon dioxide laser. So conception can be planned as early as 10 to 12 weeks. Endometriosis, you can use CO2 laser vaporization. So the endometriotic lining can be removed or fulgurated. That's how the laser works. A study concluded that excising deep endometriotic lesions can improve IVF outcomes. PCO, just do the laparoscopy only when it is justified. For example, the patient has uterine malformation concomitantly with the PCO or for tubal patency diagnostics. So just ensure that the patient is selected carefully for this drilling. Don't just do it as a routine. So obesity, low basal LH levels, that is less than 10, and marked hyperandrogenism, high AMH more than 7.7 ng per ml are predictors of poor response. So 40 watts, 4 seconds, 4 punctures per ovary. Cool the ovaries by dipping in normal saline. So it is crucial, this is the conclusion, it's crucial to keep in mind that regardless of the underlying illness, wisdom lies not in knowing when not to operate, when the risk outweigh the benefits. So thank you for your attention.